Good evening, everybody, and welcome to the ICS Sleep Certification course. This is the sixth in the line of the continuous certification courses that are being held. Thank you very much for joining. I am Anand Mohan from the Department of Pulmonary Critical Care and Sleep Medicine at AIIMS, New Delhi, and basically this sleep certification course is today on a very important topic, which is on hypersomnia and excessive daytime sleepiness, how to approach, how to manage. So what has been decided is that we have got together a very eminent faculty, extremely experienced and qualified faculty for you, in which we will have a short talk first on this particular topic, and then we will have our a panel discussion, a general panel discussion with all the other faculty also joining in, so that we are able to cover again by means of question answers, to cover almost the entire topic in its entirety once more. At this point of time, I would like to first of all thank the Indian Chess Society. They, under their banner, this is going on, and a host of very successful webinars are continuously being conducted. And Dr. J.K. Samaria, the president, Dr. Amita Nene, the chair of the educational inputs, the Dr. Rajadhar, the secretary of the ICS, all of them have been instrumental in bringing this here. As also would like to thank the sponsors, the CIPLA, which has been sponsoring this throughout. So thanks to them and their entire team, and also thank you to Mr. Hitesh, who's also been the kind of very strong support behind this entire event, and organizing and handling and coordinating everything together. So with this, I think we'll start off today's session, and today's session will start with a first talk on approach to hypersomnia and excessive daytime sleepiness, and this will be delivered by Dr. Paramez AR. And Dr. Paramez is a senior consultant, and he's the head of the pulmonary medicine department at the Lissi Hospital at Ernakulam. He has several achievements and awards to his credit. He's the national governing body member of the ICS, president of the Cochin Thoracic Society. He's been associate editor of still the associate editor of Journal of Advanced Lung Health. He has awards, awarded Best Young Pulmonologist in 2021. He has organized several major events like the NAPCON 2019 and BronchoCon, and also written papers, edited chapters and textbooks, and has been a faculty in several conferences and workshops. So with this, Dr. Paramez, I'd welcome you, and I'll invite you to please start your talk on approach to hypersomnia and excessive daytime sleepiness. Over to you.
Thank you, Dr. Anand Mohan, sir, Indian Chess Society, Dr. Amita Nene, J.K. Samaria, sir, and Rajadhar, sir, for giving me the opportunity. I will quickly start the slides. Slides visible? Hitesh?
Yeah. Yes.
Yeah, fine. So, good evening to you all. So, after a few successful modules on the sleep, we are going to discuss about some of the other factors of sleep disorders, which we are not that frequently see. So this is about excessive daytime sleepiness, which we usually see, and hypersomnias, which we usually see. But the causes of these that we usually see, being the sleep disordered breathing, has been already discussed in the modules. So we will be discussing about certain other reasons of this. So what is the definition of excessive daytime sleepiness? It is defined as difficulty staying awake or alert, or an increased desire to sleep during the day. It should be there for at least 3 months. And there are various reasons for that. Like I mentioned, an inefficient sleep, like a social cause, shift works, stress, depression, drugs, illnesses, pain, may be causes for daytime sleepiness. because you may not be able to sleep at night. Sleep-related breathing disorders like the OSA, CSAs, OHS will also, the patients will be having excessive daytime sleepiness despite having a proper management of that, maybe using their CPAP devices and still maybe having EDS. Then you have to evaluate for other causes as well. Circadian rhythm sleep-wake disorders like jet lag, delayed sleep-wake phase disorders, advanced sleep-wake phase disorders, etc. Sleep-related movement disorders like restless leg syndromes, periodic leg movement disorders also causes EDS. But what we are going to discuss today mainly and focus today is the central disorders of hypersomnolence. So, DD of excessive daytime sleepiness, as I already mentioned, in insufficient sleep, deprivation, certain sleep disorders like OSA, central disorders of hypersomnia, somnolence, and sleep rhythm wake disorders. Other CNS diseases like Alzheimer's, myotonic dystrophies, multiple sclerosis, traumatic brain injuries, medical and genetic disorders like hypothyroidism, which is a treatable cause, end-stage renal disease, adrenal insufficiencies, hepatic encephalopathies, etc. Psychiatric disorders always need to be on your cards, differential diagnosis, and also the medication. You have to always check the medications list before going in further to evaluate excessive daytime sleepiness, like the benzodiazepines, antipsychotics, opioid analgesics, antihistamines that we commonly use, etc., etc. As I already mentioned, we will be discussing more about the central disorders of hypersomnolence today. So what are central disorders of hypersomnolence? This is characterized by a complaint of hypersomnia, that is excessive sleep, which is not attributable to another sleep disorder, disturbing the nocturnal sleep, like an obstructive sleep apnea or an insufficient sleep or a circadian dysrhythmias. And it is also an inability to remain awake or alert during the major wakefulness episodes of the day, resulting in daily periods of irrepressible need to sleep, or whole daytime elapses into the sleep. This can also be the definition of central disorders of hypersomnolence. And the reasons being narcolepsy, 1 and 2, Klein-Levin syndrome, idiopathic hypersomnia. These are the three that I'm going to discuss predominantly, and also due to medical disorders and psychiatric disorders, as I have already mentioned in the table. Coming to narcolepsy. Narcolepsy is a central disorder of hypersomnolence characterized by excessive daytime sleepiness in all the patients who are having this disorder, along with the additional symptoms of cataplexy, which occurs in type 1 narcolepsy only, disrupted nighttime sleep, sleep paralysis, hypnagogic or hypnopompic hallucinations. I'll come to that in the future slides. So these may or may not be present in patients with narcolepsy. Coming to narcolepsy type 1, this is narcolepsy associated with cataplexy. It is caused by deficiency of orexin, sorry. And second one is type 2, which have got all the clinical features of NT1 except cataplexy and low orexin levels. Incidence is 0.74 per 1 lakh per person years, and peak incidence occurs in second and third decades, and prevalence estimates to about 25 to 50 per 1 lakh people. Males and females are almost equally affected. NT2 estimates around 20 to 30 per lakh population prevalence. Features I've already mentioned. All patients with narcolepsy have chronic daytime sleepiness, and they do not sleep more than healthy individuals during 24-hour period. They do not sleep more than healthy individual if it take 24 hours period. They are prone to falling asleep throughout the day, often when sedentary and at inappropriate times. And they do get sleep attacks. They just fall off during the daytime. And their sleep is usually restorative, because most of them, if they don't have any other coexisting problems like an OSA or an OHS, the sleep is refreshing. So this is one thing that you need to understand as compared to other sleep disordered breathing where their sleep is not refreshing. Usually it is associated with cataplexy, as I already mentioned. It is emotionally triggered transient muscle weakness and are triggered by strong positive emotions, basically like laughter, joking, excitement, etc., but also can occur with intense anger, frustrations, etc. And other feature is hypnagogic hallucination, which are vivid and often frightening visual, tactile, or auditory hallucinations that occur in patients while falling asleep. This may be because of a mixture of wakefulness and dreams happening during the period of REM sleep, which occurs in narcolepsy. Third is sleep paralysis, which also occurs during the sleep and 1 or 2 minutes when awakening or when falling asleep. Can be a frightening thing because the patient may be immobile along with hallucinations and sense of suffocation. The sleep may be fragmented as well, and there may be other features of other sleep disordered breathing like OSA, periodic limb movements, etc., can also coexist with narcolepsy. So focus questions that you ask in a patient suspected to have narcolepsy are you sleepy most of the day because sleepiness is present or not? Do you feel rested upon waking in the morning? Are your naps refreshing? And do you have vivid dreams? Do you ever have muscle weakness when you tell a joke or laugh? That is called cataplexy. Do you ever see, hear, or feel things that you know aren't there as you are feeling asleep? That are hallucinations, hypnagogic hallucinations, and focused history about sleep paralysis as well. And also quantitate the number of problems with a Epworth sleepiness score. If answer to any of these questions is yes, narcolepsy should be considered, and both a polysomnogram, which we usually do for ruling out sleep disordered breathing, and followed by a multiple sleep latency test should be performed. If any of these questions, one of the answers is yes, then you have to go for the testing, both these testing. So then comes to the topic per se of evaluation of EDS or / narcolepsy, because the chunk of the topic will be dealt as narcolepsy only. As I already mentioned, ESS, you all know about Epworth sleepiness score. It's been there for the evaluation of sleepiness in the daytime, where you give the situations like sitting and reading, watching TV, sitting inactive in a public place like in a theater or a meeting, as a passenger in a car for an hour without break, lying down to rest in the afternoon when circumstances permit, sitting and talking to someone, sitting quietly after lunch without alcohol in a car while stopping for a few minutes in traffic. It's a quick office test. Basically, it assesses the patient's propensity to fall asleep during all these scenarios, and patients are asked to score it from 0 to 3 according to the chances of dosing. And the score will be, if it is less than 7, it is normal daytime sleepiness. If it is 8 to 9, mild. If it is 10 to 15, it is moderate. If it is more than 16, it is severe score of excessive daytime excessive sleepiness. Second is a sleep log or a sleep diary. When your patient is having a suspected any kind of sleep disorder, you ask the patient to have a sleep log or a diary where it will assist in documenting sleep and provide a visual aid to the patient and the physician. Patients record their bedtime when they are going to the bed, the wake time, number and time of arousals in between, how long it took to return to sleep after an arousal, frequency and duration of naps, bedtime events like when did he had the food, alcohol, physical activity, etc. This is it's not clear, but it is taken from the up-to-date about 15 score questions for a patient to be asked about to be given as a sleep diary questions. This is the one and the same that I have already mentioned, and the patient has to score it in their list. The objective form is to do a polysomnography, and it is basically to exclude an alternative and coexisting causes of chronic daytime sleepiness warranting specific treatment, and to evaluate for further supportive diagnosis of narcolepsy. So PSG is a must before going for an MSLT in patients suspected to have narcolepsy. Spontaneous awakenings, mildly reduced sleep efficiency, and increased light non-REM sleep on PSG are all supportive but non-specific. REMs within 15 minutes of sleep onset at night during a PSG is also indicative of doing an MSLT, indication for doing an MSLT, because you have to exclude the narcolepsy. That is sleep onset REM periods. This is within 15 minutes of sleep in a PSG. The fourth evaluation is an MSLT. MSLT is multiple sleep latency test, where the patient is objectively assessed for his drowsiness by determining an individual's propensity to fall asleep. It is primarily indicated for evaluation of narcolepsy and in suspected cases of idiopathic hypersomnia, that is a differential diagnosis of narcolepsy. Test is performed following an overnight PSG and to confirm an adequate amount of sleep, because at least 6 hours of sleep should be documented in the overnight PSG to do the MSLT. MSLT is done in the daytime, where the patient is given opportunity to have naps of at least 5 naps of 20-minute duration in a dark, comfortable room. Each nap duration is between 2 hours. The frequency is between 2 hours. There should be a gap of 2 hours. The mean sleep latency is determined by averaging the time from the lights out to sleep onset during each of the nap periods. And usually for a normal individual, it is more than, the sleep latency is more than 11 minutes over the 5 nap periods cumulative. As MSLT is valid only, I already mentioned, it is valid only if the PSG demonstrates at least 6 hours of sleep in the prior night. In narcolepsy, what happens in MSLT is that the mean sleep latency will be less than 8 minutes, and in severe cases, it's usually less than 5 minutes, which is consistent with pathological drowsiness. And in addition, the occurrence of REM sleep within 20 minutes of start of the nap period, also called sleep onset REM period, is also noted in these MSLT cases. If there are 2 or more SORMs, that is sleep onset REM periods, then in that 5 sets of MSLT, then it is suggestive of narcolepsy. It assists in distinguishing idiopathic hypersomnia from narcolepsy without cataplexy, that is type 2 narcolepsy. MSLT helps in that, because in narcolepsy, there will be the number of SORMs will be more than 2. In idiopathic hypersomnia, it may not be there, and also the latency may not be less than 8 in that cases. And SORMs that immediately follow stage 1 N sleep may be more specific for narcolepsy than those that follow the N2 or N3 sleep. Usually what happens is in a normal individual, N1, N2, N3 followed by REM, but in narcolepsy, after the N1 immediately goes to REM sleep. That is also suggestive of narcolepsy. Another test is maintenance of wakefulness test. It is also being done where the patient is advised wakefulness test consisting of 4 40-minute trials conducted every 2 hours. A preceding night PSG is not required in this, where the patient's wakefulness is actually whether the patient is able to stay awake during that period of study is assessed. A mean sleep latency of less than 8 minutes is considered abnormal. It's just like the MSLT, but it is about the being wakeful during the daytime. It is also performed in patients suspected to have narcolepsy and hypersomnia and having significant public risk like drivers and all transportation industry. The wakefulness test has to be assessed. And if the wakefulness test is positive, then we need to change the profession of that individual, or if not a professional driver, you have to give advice regarding the driving in those patients if the MSLT and the MWT is positive. It also is used to assess the response to therapy for hypersomnias. The CS of orexin A testing is also being done to detect whether it is NT1 associated narcolepsy. If the MSLT and other things are positive, the CS of orexin test is also being done. Now, just quickly going to the criteria for narcolepsy type 1, where I have already mentioned about the clinical history, and followed by the MSLT, where there will be a cataplexy and a MSLT of less than 8 minutes and a SORM of less than 15 minutes of sleep onset, and also the criteria of CS of orexin level. Orexin is the hypocretin, one and the same, hypocretin 1 and the orexin. Less than 110 picogram per ml is diagnostic of type 1. If it is not, if the CSF level is more than that, then it is type 2, where the orexin levels are not decreased. This is the flow chart where you need to means if the patient is suspected to have cataplexy and hypersomnia and sleep paralysis. If the patient is having cataplexy, if the answer is yes, then directly go for the PSG and MSLT and diagnose accordingly as per the criteria. If the criteria is meeting, narcolepsy type 1 is confirmed. If it is not meeting the criteria, then obtain the CSF. If the CSF is less, orexin levels are less, then it is narcolepsy type 1. If it is not, then as the question about the hypnagogic hallucinations and sleep paralysis, whether it is occurring more than 3 times per month. If it is less, if it is yes, it is narcolepsy type 2. Or if it is not, if there are no hallucinations, sleep paralysis, nothing, then you have to evaluate for other causes of excessive sleep, daytime sleepiness. And if the patient does not have cataplexy, then also you have to go for these 2 tests. And if it is the sorums are more than 2 on MSLT, then it may be narcolepsy type 2. And if it is unreliable, then you have to assess for further evaluation for other causes of daytime sleepiness. And whether if there is any other sleep modulating medicines are there, then after correcting that sleep modulating medicines, you again go for the repeat MPSG and MSLT and diagnose it, whether it is narcolepsy or not. Treatment is basically non-pharmacological treatment is to give behavioral therapy and give good napping and sleep hygiene. 2 timed naps in the daytime should be provided. Comorbid sleep disorders, if OSA and all things are there, should be managing that. Avoidance of CNS depressants are a must. Psychosocial support is a must, especially in the workplace, because the patients may be cataplexic and you have to support them. Psychiatric counseling and treatment of depression and anxiety may be there, will be there in those patients, and has to be treated accordingly. Cardiovascular risk factors like the sudden shooting of BP may be there in those patients, especially those who are on stimulant drugs. Then it has to be managed. Obesity has to be controlled, and driving safety advice has to be given, and avoid long drives, highway drives, night drives, after a meal drives, etc. needs to be advised. And to advise to take stimulants before driving is also a thing. This is a slide set of the drugs that we use for narcolepsy management. The first line management for excessive daytime sleepiness that we all use is modafinil. It should be used at a dose of 100 to 400 milligram every morning, or 200 milligram twice per day. The side effects are all mentioned here. And another modified form is R-modafinil, where it is started at 150 to 250 milligram every morning. And all these have side effects of headache, so you have to be aware of that. Another one is solarium fetol. This is a new molecule which can be given for EDS patients at a low dose at 75 and escalate to 150. And pitolisant is an antihistamine histamine drug, basically histamine analog, and it is also a new drug which is available for treating the EDS. Methylphenidate can also be used to increase the wakefulness in the daytime. The other drugs that we use is amphetamine analogs, and the sodium oxybates are also being used quite extensively nowadays. Other drugs like the antidepressants like fluoxetine, clomipramine, and triptychans can also be used to treat the EDS. And disrupted nighttime sleep, if it is there, then you can give solpidem or sodium oxybates for the management of disrupted nighttime sleep in patients with narcolepsy. This is the treatment chart of excessive daytime sleepiness patients. So symptomatic management, I already mentioned about the general measures, and then when the problematic sleepiness occurs, then you have to give the medications, first line wake promoting medications like the modafinil, pitolisant, or solarium fetol. And if there is no improvement, then you have to add other drugs like fluoxetine, TCAs, etc. If there is mild to moderate, then and if there is well controlled, then you can continue with the second line wake promoting agents as well. And I think women need not know about the extensive use of the drug therapy in these patients, because most of the patients will be managed with the modafinil treatment in this case. This is the drug chart, in the flow chart of the treatment. So ASM recommendations for the narcolepsy treatment is the strong recommendations are to use modafinil and to use pitolisant if not getting better with modafinil, and or also sodium oxybate. The second variant is the Klein-Levin syndrome, or the recurrent hypersomnia, or the periodic hypersomnolence. It is just like the narcolepsy only, but do have some other phenomena, like most of the patients will be in the adolescent group, recurrent episodes of severe hypersomnia in the day, and also will be having cognitive and behavioral disturbances like confusion, derealization, apathy, compulsive eating, and hypersexuality. It's a rare sleep disorder. Etiology is unknown, with male predominance at the age of puberty. Diagnostic criteria, according to ICSD-3, is all the criteria should be met, like the patient experiences at least 2 recurrent episodes of excessive sleep, daytime sleepiness, and sleep duration, each persisting for 2 days or to 5 weeks. Episodes recur usually more than once a year, or at least once every 1.5 years. Patient has normal or near normal sleep, wakefulness, cognition, behavior, and mood in between the attacks. And patient must demonstrate at least one of the following during the episode, like as I already mentioned: cognitive dysfunction, derealization, apathy, and disinhibited behavior. The symptoms and signs are not better explained by chronic insufficient sleep, a circadian rhythm sleep-wake disorder, or other current sleep disorders. So other things are excluded. So management is mostly non-pharmacological. A safe sleeping environment needs to be given, educating the caregivers and teachers about the disease, and managing the kid with a good safe sleeping environment. Monitoring for the medical and psychiatric complications is essential. Patients with disabling anxiety, suicidal ideation, and potentially dangerous delusions and behavioral disturbances should be evaluated by the psychiatrist. Severe anxiety and psychosis are associated with this, and may be treated symptomatically with benzodiazepines and antipsychotic agents. Stimulants, as compared to narcolepsy, are better avoided because the patients will be more anxious, and it's better to give a safe sleeping environment rather than making them awake by giving stimulants. Most patients feel better by sleeping, and stimulants are poorly tolerated due to increased anxiety. For prolonged episodes, there have been studies showing that high-dose glucocorticoids at the onset of the next episode may be given, like 1 gram of methylprednisolone per 3 days, and then followed by gradual tapering over the next 1 to 2 weeks can be given. A trial of lithium to prevent further episodes can be also tried. The third one that I'm going to discuss is the idiopathic hypersomnolence. It is a differential diagnosis of narcolepsy. That is, it is also a central disorder characterized by at least 3 months of daily periods of irrepressible need to sleep, or daytime lapses into sleep or drowsiness. Then orexin levels will be normal, and the PSG MSLT I have already mentioned in the talk during the narcolepsy. Short sleep latency, increased total sleep time, increased sleep spindles, increased stability of N2 sleep, and variable changes in sleep efficiency and sleep stage distribution. The latency may be shortened, generally less than 8 minutes, but the number of SORMs will be less than 2. That is the differentiating feature with the narcolepsy. So usually it is treated by just like narcolepsy only, by wake promoting agents, modafinil, solarium, phentol, or pitolisant, or stimulants like methylphenidate or amphetamines. The other non-pharmacological treatment, like sleep hygiene, scheduled daytime naps, and avoidance of sedating and alcohol, drugs are also to be given. These three are the major things that I wanted to discuss during this sleep module. And to summarize, a pulmonologist should know about the sleep disorders other than the sleep disordered breathing. Though rare, hypersomnolence has a significant social, psychological, and health-related impact on affected individuals, their family, and society as such. A systematic approach will help in differentiating these disorders from other common sleep disorders. This I thank you for your patient listening, and I'll be happy to take questions, especially during the panel discussion. Thanks.
Thank you very much, Dr. Paramez. You have made in a very short and crisp manner, in a short period of time, you have been able to explain a relatively difficult and less understood topic in a very simplified manner. I think that really is wonderful, and and giving very crisp messages. I think that will have really gone well with the audience. Now, what we'll do is we'll start with our panel discussion, and of course, then I'm sure we'll revise many of these points again during the panel discussion, because the whole idea is that whatever is being taught, being told, for example, in this lecture, it might be repeated, because only then it gets hammered into the brain, and with a lot of our postgraduates and all logged in, so that would help. So now, without wasting any more time, I would like to introduce our panelist over here today. We have got a very eminent faculty as our panel, and I'll introduce them to you one by one. We have Dr. Sushant Meshram, and he is well known to all of you. He is currently the head of Department of Pulmonary Medicine at the Government Medical College at Nagpur. He is a fellow of sleep medicine at John Hopkins, and he's a fellow of the American College of Chest Physicians also. And he has been mentor, and he has done fellowships in sleep medicine and others. He's been examiners. He's SSC of various colleges and expert committees. So all these activities he's very actively involved in. He has several honors and awards to his credit as well. And I think you can see on the screen also all the things he's been involved in, whether it is administration, whether it is clinical work, policy making, educational activities, holding conferences, publications. So all of that is there, and you can see that he's been really very eminent person in the field of respiratory medicine. So welcome, Dr. Meshram. And
Thank you, sir.
next would be Dr. Archana B. And Dr. Archana is the professor at the Raja Rajeshwari Medical College and Hospital in Bangalore. Also highly experienced senior consultant. She has got ERS certified thoracic ultrasound trainings, and also sleep medicine training courses being attended, and being competent in that. She has led many national and international clinical trials, reviewed articles for several high ranking journals, and also is an investigator for the National Bronchiectasis Registry, as well as being involved very actively in several areas of education and medical education as well, along with publications in national and international journals, and also has presented papers at various international conferences. So welcome, Dr. Archana, to the webinar today.
Thank you, sir.
Next, I'd like to introduce Dr. Mahesh Jansari. Dr. Mahesh is Associate Professor of Pulmonary Medicine at AIIMS Kalyani, and again, very young, dynamic, but highly experienced at the same time. He's been awarded best paper at state level conferences. He's also many other prizes, awards to his credit. He's editor of the Indian Association of Bronchology, also a founder member of the CCI, and has multiple publications and book chapters, and also very actively engaged in organizing conferences and workshops at the national level. So welcome, Dr. Mahesh.
Thank you, sir.
Next, I'll introduce Dr. Tanvi Bhatt. Dr. Tanvi Bhatt is a consultant at the chief pulmonologist at the Zanova Shalby Hospital at Mumbai, and formerly at the Seven Hills Hospital in the Mumbai itself. And again, welcome, Dr. Tanvi. And with all this, and of course, Dr. Paramez will be with us after his talk. He also is part of the panel. So I think we have a very good good mix of youth and experience, and we have a fantastic faculty today. And now I'll start off with the questions.
1 second, sir. Let me introduce you as well. Because the crowd, because it's my privilege, honor, and pleasure, basically, to introduce our beloved moderator, Dr. Anand Mohan sir, who needs no further introduction actually, but still. Uh, I'll definitely introduce Dr. Anand Mohan, our moderator for the day, who is the professor and head of the Department of Pulmonary Medicine, Sleep and Critical Care at All India Institute of Medical Science, New Delhi. And he's a fellow of Royal College of Physicians, National Academy of Medical Sciences, and member of IASLC and Indian Association of Study of Lung Cancer as well. Publications more than 350. I don't know about his counts. Book chapters of more than 10. Editor, associate editor of Lung India, principal investigator in more than 25 studies, organizing chairman of AIMS Pulmocrit, and various awards to his credit. Over to you, sir, for keeping this discussion and also guiding us how to prepare the topic and also how to present the case. Thank you.
Thank you very much. Thank you. Before I start, I would also request the audience, which are there in huge numbers, that if you have any questions, please feel free to post the questions on your chat box and we'll simultaneously keep on seeing them. My only request is to please restrict your questions to the topic of today. So because we have many more webinars coming up and many more topics will be covered, we would like to restrict to the topic today in order to maintain the focus and also the time. At the same time, I would request the faculty also to be please be crisp and brief in their answers because that would really help to get the people to learn whatever they have to learn. So we'll start off first, and we'll start off with Dr. Shushant, with you to just start off in a simplified manner the topic for today. Again, can you just revise for us what exactly is hypersomnia and what are the types of hypersomnia?
At the outset, I would like to thank ICS and the chair of the ICS, Samaria sir, Raja the secretary, and Amita Nene madam, and of course the most eminent moderator, Dr. Anand Mohan, and my faculty panelist. The topic has already been very well dealt by Dr. Parmesh. The hypersomnia, the name itself, somnia is a Latin word for the sleep. So hypersomnia means the person or individual who is having more tendency or excessive tendency to sleep even during daytime, in spite of having enough sleep time during night. So these group of the individuals, they have tendency to fall unintentionally during, for example, any work or talking or eating, even walking also. So, and usually this hypersomnia is accompanied by cognitive dysfunction and there is a impaired quality of life. So this is what a hypersomnia. And if you ask for the types of hypersomnia, as already we discussed, the types of hypersomnia would be primary or secondary. Primary, basically there are three disorders which are central disorders of hypersomnolence. That is what neurologic, narcolepsy, then Klein-Kevin syndrome, and idiopathic hypersomnia. These are the three main disorders which comes under the primary hypersomnia. Then secondary hypersomnia means apart from these disorders, like previously has been discussed regarding the sleep related breathing disorders and the psychiatric related this hypersomnia, psychiatric disorder related hypersomnia, hypersomnia due to medications or some neurodegenerative medical disorder like Parkinson's and what you can say Alzheimer. And in certain condition, even post-infectious also, the person may have hypersomnia. Like we have seen in the COVID pandemic that many of the patients, they used to complain of hypersomnia as well as insomnia also. So these are the certain causes of secondary disorders. And other sleep disorders like circadian rhythm disorders and what you can say, the disorders due to irregular sleep pattern. So I mean, those who are working in the shift-wise duties. So these patient, these subjects may also complain of hypersomnolence, but this has not to be classified as a hypersomnia. So basically, the disorders which are central and can be classified as a primary hypersomnia, and other can be classified as a secondary hypersomnia.
Yeah, thank you. So I think the definition is quite clear. Types are also quite clear. Just to remember, primary hypersomnia, that for which no other disease is identified as the cause, or there is no other cause. For example, you have other disorders also, like other disease states, like for example in ILD you have idiopathic ILDs in which there is no cause, and then you have the secondary ILD, which are the CTD ILDs, in which you have the cause. Similarly, here secondary hypersomnia is one in which you have some cause which is causing that problem. In the primary variety, there is no etiology per se. So then you have to classify as a primary. So this is the, broadly speaking, the difference between the two, if we can call it in a very simplified manner. So we'll move on to Dr. Archana. For you, the question is, what is the other thing we were discussing today? What is excessive daytime sleepiness, and anything about it incidence? How common is it, and what, just briefly, what are the common causes?
First of all, I would like to thank Nene Madam and ICS for giving me this opportunity. Coming to the question, this was Dr. Parmesh's first slide itself. Excessive daytime sleepiness is inability to maintain wakefulness or alertness during the major waking episodes of the day, wherein the sleep occurs inappropriate time almost daily for about 3 months. And it's a more common condition occurring in about 4 to 20% of the population. In one of the US based study, the incidence is as high as 28%. And the common causes for EDS include sleep deprivation, poor sleep hygiene, decreased sleep quality, sleep disorders like excessive obstructive sleep apnea, narcolepsy, circadian rhythm disorders. We have medications causing EDS like antihistamines and opioid analgesics, psychiatric disorders, neurological disorders, and also substance abuse and alcohol abuse causes excessive daytime sleepiness.
Right, thank you. So again, so EDS basically is a kind of a symptom, isn't it? It is a symptom that a person is feeling sleepy most of the time of the day. Hypersomnia, on the other hand, probably I would say it is a disease. It is a kind of a syndromic disease in a way, which has been classified as primary, secondary, as already told. So that may be one differentiation. Dr. Mahesh, I'll come to you with the next question. Is Dr. Mahesh is there? Yeah. So, Dr. Mahesh, what do you think will be the, so suppose a person has got hypersomnia, what can be, why should we be worried? What can be the consequences of hypersomnia per se?
First of all, I would like to thank ICS, Amita Madam, Radhadhar sir, and Samare sir for giving us an opportunity and devising such a very different.
Could you just increase the volume a bit if possible? Just.
Sir, am I audible?
Yeah, better.
So as we know that hypersomnia is a condition where a person has a tendency to fall to sleep repeatedly and especially during the daytime. And obvious consequences would be related to decreased alertness, like it may cause accident, and this accident may be very detrimental from a personal and public point of view. Also, it may cause the impaired cognitive function as well as it may cause mental health issues, like it can affect the work and it can affect the academic performance as well as the personal social life relationships. Also, it increases the need for the stimulant to stay alert, and this can lead to a substance abuse. Overall, it may cause reduced quality of life, and because of the low alertness and inactivity, it may cause various cardiometabolic disorders like obesity and other cardiac complications. Overall, due to this hypersomnia, there is a decline in personal and professional productivity, and it may lead to a mental disorder, especially the depression, or it may increase the chances of suicide and etc.
Right. Thank you. So I think that's why it is not just a very benign kind of a disorder. It has its complications, it has its consequences. So that is important for us to know that consequences may not be immediate. Consequences may not be very severe initially, they may be, relatively subtle initially, but over a period of time, if the problem persists, then you may have all these things, like you said, cognitive problems, social problems, so many issues in the long run, and that really hampers a patient's quality of life, apart from the fact that it may really lead to dangers like accidents, etc. as well. So I think that is why it is not something to be just ignored, and one has to try and find out the cause and also treat it. Dr. Tanvi, I'll come to you now. Yeah. So, Dr. Paramesh did talk about the Epworth sleepiness scale. We are talking about the excessive daytime sleepiness. So, obviously, we will have to talk about this as well. So, can you just tell us what is this scale basically? What is the importance? What will be the clinical and practical utility of this particular scale in our routine practice?
So first of all, I would like to thank Indian Chess Society and Dr. Amita Nene Madam to give me this opportunity to be a panelist in this topic. Dr. Parmes has very well explained the entire spectrum of sleep disorders. So now when talking about Epworth Sleepiness Scale, it is a self-administered questionnaire which a patient can answer. It is to screen all types of sleep disorders like obstructive sleep apnea, idiopathic hypersomnia, and narcolepsy. We do, sir has very well explained the scores. Anything more than 16 is severe, and anything more than 10 will raise a concern for a pulmonologist who is evaluating the patient. And it is also used to monitor how the patient is doing after being diagnosed and after being treated. So how it differs from other scores, in that we see the nighttime symptoms and daytime symptoms when we see obstructive sleep apnea. But this score is only for daytime hypersomnolence disorders. So this is how we differentiate all daytime sleepiness disorders. That is the first utility. Second will be to monitor response to therapy. So if any patient of OSA has been started on CPAP, how is the patient doing? If the patient of narcolepsy is being treated with pharmacological or non-pharmacological treatment, how the patient is doing. So it's a very basic tool to evaluate how the patient is doing.
Okay, thank you. Yeah, so it's a reasonably well known, and also it has been well studied, and it has been found to have pretty high degree of sensitivity and diagnostic utility for the particular reasons that you have told, and also for the particular indications for evaluation of excessive daytime sleepiness, and also as a monitoring tool in a way to assess for the improvement following some therapy which has been initiated. So that is something, and this is something which can be easily done in the OPD setting. In fact, it is being routinely done in the OPD setting as well. All right. So I'll move on, and I'll pick up Dr. Paramesh. I'll come to you, and just one question I'm picking up from the chat box. One question which was asked, that what clinical clues help to distinguish narcolepsy from other causes of hypersomnia? Again, an important question, because these are the problems that one faces. So can kind of shed some light on this?
Yes, clinically, for a narcolepsy patient, especially the type 1, if the cataplexy is there, then it is diagnostic. Then you just need to just do the MSLT, and 100% of the time it is going to be positive if the cataplexy is there. If there is no cataplexy and if there is excessive daytime sleepiness only, then these other evidences, as I already mentioned, these hallucinations and hypnagogic hallucinations, sleep paralysis, all this history will be important as far as clinical clues are concerned. And especially when you are having a clinic, when the patient comes to you, or the patient's bystander comes to you with the symptoms, most of the time we'll be doing a in-lab PSG. And the in-lab PSG will give you a clue about this SORMs. About means after the N1, the patient goes into the REM directly. The REM latency is less in those patients with narcolepsy as compared to most of the other sleep disorders. But as I mentioned in the differential diagnosis, there are certain other hypersomnolent states where the sleep SORMs are low, like the latency is low, like the REM onset will be very quick. but this the count of sorums is pathognomonic of narcolepsy, and you will be with all these things you will be able to means differentiate. In type 2 it is a bit difficult, and then we may need to have this theoretical thing of or to do a CSF analysis and all, which I don't know whether it is available in our setup or not.
Correct. I was about to come to that
Yeah.
only. You know that there is a lot of emphasis in your slides on the CSF being there, but practically speaking, I
It
don't
is not.
think
It is not. Yeah, it
yeah,
is
I don't think
theoretical.
it has any utility when one will have to go with clinical parameters
Clinicals.
and the tests which you have already
Yeah,
mentioned.
Dr. Anand, shall I add one thing to it?
Yeah, Dr. Sushant, please.
In this hypersomnolence or excessive daytime somnolence in narcolepsy, the episode of that somnolence is followed by refreshment. I mean,
Yes.
patient is not that drowsy or that he may feel refreshed, but in other type of hypersomnia disorders, the patient will have some confusion or non-restorative sleep, what you can say. So this is one clinical clue you can get, that whenever the person who is in hypersomnia and is falling asleep, and after falling asleep he feel refreshed, then it's more likely towards the narcolepsy. Yeah.
Right. Okay. Right. So that's a good pointer. And also we'll move on and I'll move on. Again, I'll stick with Dr. Parames with one more test we have talked. Can you just again tell us what is this MSLT? What is this multiple sleep latency test? You have talked about it, but again, can you just for the benefit of our audience repeat it once? And it's, because it is something which has to be done in phases, isn't it? It's a kind of a
Yes,
periodic type of test.
it should be done in phases. Basically, prior to that, as I've already mentioned in the main talk, you have to initially, first of all, after the clinical assessment, excluding all the secondary causes like other diseases and all, then first you do is to conduct a proper polysomnography, where you assess the REM latency and also the exclude other sleep disordered breathing as well. If there are severe or obstructive sleep apneas or CSAs happening in the PSGs, so and also have to ensure that patient do have at least 6 hours of good night sleep before going into MSLT, because what we are actually noting is to exclude narcolepsy. Even if the patient does have an good night sleep, a patient with narcolepsy will have an excessive urge to sleep in the daytime. So that's why the MSLT comes into play. So if he has not slept properly, then there is no point in doing an MSLT, because it may give a false positive result. Like if you haven't slept for at night because of some other reasons, then you will definitely sleep in the daytime, and your REM may be also be developing in those sleep naps. So what happens in MSLT is you do give at least 5 episodes of 20-minute naps, 2 hours apart. That is what we usually give, and patient is has to sleep in that dark room itself, and it should be noise proof as well, sound proof. And the way we conduct the PSG in the same lab itself, we do the multiple sleep latency test, and we give the extra nap periods for those patients, and we assess the sleep latency and the sleep stages, and see if the REM sleep is happening and how many times the REM sleeps are happening during those period. This is exactly what we do in the MSLT thing. And the criteria that I already mentioned in the slide set. One question that I have seen in the chat box, can I answer it, answer?
Yeah, sure.
Regarding why the 24 hours period, the narcolepsy, the sleep time is static, the same.
Yes. Yes.
Basically, when you see the
So can you just
narcolepsy,
tell the question once more for the audience? The question is,
question is, I've seen it somewhere.
why is the total sleep,
That
why
is
should the
from
total sleep time be normal in a narcolepsy
normal.
case?
Yeah, this is from I think Kiran.
Yeah.
Kiran, who is a close friend of mine from Trivandrum. Why would this total sleep time be normal in a narcolepsy patient? So basically, narcolepsy patient, the sleep time may be normal, or slightly increased basically. So why so is because the patient's night sleep may be fragmented, and the good night sleep may not be achieved, and also he may be sleeping normally for the at the night, and these episodes will last for a few minutes to hours only in the daytime. So and the night sleep will be fragmented, so the total sleep time will be almost same or slightly increased as compared to general or other sleep disorders.
Yeah, I think that's a good point. And so basically, one thing, Dr. Parame, that means when we do a MSLT, the first thing is a PhD, proper PhD should be done before that.
Yes.
So that is, I think, the first one message which should go to everybody.
Yes.
And after that, then so the important thing for everybody will be to understand what would be the time when they decide, okay, now this person needs a MSLT.
The basically in the PhD means your history is the key basically, and then once the PhD is showing huge amount of REMs, then with less REM latency, then go for the
Correct.
MSLT
Correct.
test.
Then we go for the MSLT test, right? Okay, so we move on now, and Dr. Sushant, I'll come to you now. Uh, we talked about the MSLT. Now, can you tell us about the other test which was talked about, the maintenance of wakefulness test? What is this test? Its indication? When should we do? How is it done? Very briefly, and what does it diagnose? You are mute, I think, Dr. Sushant.
Yeah. As the name itself suggests, that it's a maintenance of wakefulness test. So here we are going to assess the ability of an individual to remain awake, and this is an objective assessment. And again, it is being performed in the same way as the MSLT is performed. That means the room has to be quiet, there has to be non-stimulating environment, and preferably, it's not necessarily required, but preferably if the patient undergoes one night this prior night with PSG, which shows the normal PSG, then it is much better to go for the this MWT test. And the important indication for this is what? To evaluate the alertness. That means to remain awake. And specifically, it is needed in the occupation which requires to remain alert. Fine. For example, the pilots or commercial drivers, there are a lot of studies around the world that we shows that almost the very studies report 3 to 30% of the this road accidents are due to this hypersomnolence or excessive daytime sleepiness, you can say. And another important indication would be to monitor the treatment effectiveness. Whether the patient, these are the excessive daytime sleep disorders. So if you are treating this patient with whatever modalities, for example, in obstructive sleep apnea, you are treating with the CPAP. In narcolepsy, we are treating with the modafinil. So what are the modalities we are using, whether the patient is responding or not, to assess the response of our treatment, we can go for the this MWT test. And again, how it is performed, same thing. We need to perform the PSG for at least 40 minutes. And this 4 to 5 the sessions we have to perform, and the 2 sessions should have the gap of at least 2 hours. And again, the criteria of this pathology is same, that 8 minutes. If so, the person lands into sleep within 8 minutes, that means it's a pathological. Fine. Most of the 97% of the healthy individual, if suppose this test is performed in the healthy individual, so almost 97% of the individuals will have no sleep for 40 minutes. So this is how we are interpreting it. And the major difference between the MSLT and MWT is what there we are testing ability to sleep. Okay, here we are testing the ability to remain alert.
Awake, awake, yeah.
Awake, yeah.
Yeah, fine.
How,
yeah. Okay, so thank you for that. And I'll just, one more question was in the chat box, Dr. Mishram. I'll again come back to you also. That this also has been, I think, just talked. That question is, how do you approach a patient who comes with excessive daytime sleepiness, but the overnight PSG is normal? So that I think we have just addressed. What would be the next thing? If you are suspecting hypersomnia or disorder, we'll go for MSLT?
Now,
or MWT?
Yeah, definitely we should go for that. but as it is being suggested that overnight this is normal, then we need to go for some other. We need to think about some other medical disorders rather than the primary central disorders. So
So first we have to
yeah,
rule out, of course, we have to rule out
yeah,
any
yeah,
associated disorders, drugs, or anything which can cause secondary etiologies.
yeah,
So
yeah.
that has to be
Mostly.
first ruled out.
For example, the patient may be having a circadian rhythm disorder, for example, and if you are performing the PSG of this person, PSG will be absolutely normal. You know. So we need to
Right.
rule out this, yeah, other related causes for the.
So we'll move on, Dr. Archana. Again, a couple of questions for you, and we are moving on to narcolepsy again. Then, what are the types of narcolepsy? We talked about narcolepsy. What are the types? Can you just briefly enumerate?
Yeah, again, it was discussed in detail. We have two types of narcolepsy, type 1 and type 2. In type 1, narcolepsy is associated with cataplexy and deficiency of hypocretin 1, whereas in type 2, there won't be cataplexy and hypocretin levels will be normal.
Yeah. So generally speaking, why do we need to distinguish between these two? Is it any therapeutic differences? Is it symptomatic differences? Is it outcome are different? Why do we need to differentiate between the two? This anybody can answer. I mean, this is open for all these types of narcolepsy. Anybody? Dr.
Usually the
Paramesh, anybody
symptoms
want to
will
try?
be
Yeah, Dr. Archana.
Yeah, usually the symptoms will be severe in case of type 1, which will be associated with cataplexy, where the patient will have sudden muscle weakness, so irrespective of the awake condition. So the symptoms will be severe, naturally severe in the type 1 compared to the type 2. The treatment management is almost the same, mainly the
Right.
symptoms, yes.
So it is mostly the difference in symptoms and the cataplexy. The presence of cataplexy is a very prominent symptom actually, because this really makes the patient also and the relatives feel there's something really wrong going on, and that is a pretty terrifying kind of a symptom, isn't it? So that is something which is very marked in that particular type. Now, Dr. Archana, one quick question to you, which was again from the audience: how useful are sleep diaries and actigraphy in diagnosing idiopathic hypersomnia?
So usually in evaluating any sleep disorders, irrespective of what is the cause for the sleep disorder, these diaries and actinography are very important. Usually we should see the sleep log of last 7 days. This will be helpful in assessing the pattern of the sleep and also helpful in knowing which diagnostic test has to be done in that particular patient.
Right. Okay. So now we'll move on now. Right, and Dr. Mahesh, I'll come to you again, sticking with narcolepsy. So how do we diagnose narcolepsy? Again, it's a kind of a repetition, but again, I think it's important for us to be very clear.
As Dr. Parvez has mentioned previously in his talk, that narcolepsy with cataplexy is type 1 and narcolepsy without cataplexy is type 2. To differentiate both of them, we also use the origin, but the levels are, we know it's difficult to get the levels done. So the diagnosis is usually clinical with the patients have the uncontrollable periods of the sleep and the daytime propensity to go into sleep, which is at least persistent for the 3 months, and the presence of cataplexy. And on sleep study, MSLT test, sleep latency is less than 8 minutes. As well as there may be 2 or more than 2 SOREMs, and these SOREMs are they are more specific for the narcolepsy if they appear after the N1 stage immediately within the 15 minutes of the sleep onset. And if CSF hypocretin is low, it is a type 1, and if it is normal or no catalepsy, it's type 2.
Right. Yeah. So I think that kind of revises this. So we'll move on to Dr. Tanvi now, and we'll come to the treatment part. So Dr. Tanvi, treatment of narcolepsy can be either pharmacological or non-pharmacological. So can you tell us what are the non-pharmacological options for treating narcolepsy?
So, in non-pharmacological option, the first thing becomes explaining the patient and the relatives and vocational and career counseling about the entire disease that the patient is having. First, we have to explain to have a good sleep hygiene. That means 7.5 to 8 hours of good sleep, uninterrupted sleep, and with a daily same time sleep, with 2 scheduled naps during daytime, whenever the patient usually feels sleepy, but not longer naps to avoid delay of the night sleep. Second is about exercising. So, exercising, yes, should be advised, but it should not be done in the later part of the day. Third, what are the stimulants that are to be avoided? First is caffeine, alcohol, nicotine, and in food, avoid simple sugars, avoid simple refined carbohydrates. Those things have to be avoided. Fourth will be emotional support from the family, especially in terms of cataplexy. And we have to keep the person away if the patient is having cataplexy from like risky surrounding, which can be swimming, driving, or when if the patient is operating any machines. Also, we need to see the drug diary of the patient, whether the patient is taking any CNS depressing drugs, whether any medicines for anxiety, depression, hypertension, or cardiac medicines. And if the patient is having concomitant depression and anxiety, that needs to be treated either with medicines or with psychology counseling. So these are the things that can be done for a patient of narcolepsy.
Okay, fine. So I think non-pharmacological measures are as important, if not probably more important than pharmacotherapy alone, or maybe they have to be given together. But again, these things should be paid adequate attention to. I think that is the message that you would like to give, and I think we would like everybody to take home that there are several things that can be done. For example, if I take the example of say COPD, in COPD pharmacotherapy, everybody knows the inhalers, but there are so many non-pharmacological measures like pulmonary rehabilitation, the vaccinations, and all these things. Similarly, here, apart from pharmacotherapy, we have many non-pharmacological measures which should be also applied in conjunction. So I think that will give the whole thing in a good perspective. So we'll move on. Dr. Paramesh, one question I'll ask you from the audience. And the question is, what are the red flags that one should look for when we differentiate a primary hypersomnia from secondary causes of excessive daytime sleepiness?
Oh, red flags means if you are moving to include the diagnosis of for an inclusion part, yes, this cataplexy may be a red flag sign. But as far as the other excessive daytime sleepiness thing is concerned, the most common that we are going to deal with is the obstructive sleep apnea. Now
Yeah.
we have already dealt in the previous modules. We are not dealing with this. So all the problems with the obstructive sleep apnea, like the problems with the obesity, problems with the hypoxic events at night, systemic hypertension, uncontrolled diabetes, all these things will be definitely be means ruled out for the time. We do the basic investigations. The hypothyroidic part needs to be excluded. As far as these set of things are concerned, this cataplexy as well as these hallucinations are the two things that will definitely give you a sign at least to evaluate. If not properly evaluated and properly diagnosed and managed, this I have already put it in the last slide that this has got serious social as well as community troubles apart from the patient individual or the family trouble. You can have accidents, you can have major accidents or something like that. You can sleep dose off during the behind the wheel and it can cause problems. So that's the part of
Yeah. Yeah.
thing.
So I think basically what the question they tried to ask was that, so it is important to differentiate the two. You have already talked about that cataplexy, the presence of hallucinations, etc. These are frightening symptoms. These are symptoms which are very prominent and trouble the person a lot. I'm not sure, but I would like to ask the panel. Anybody can answer any whether these symptoms, the presence or absence of these symptoms, does it actually have any bearing on the outcome of the disease, or on the fact that the person may or may not respond well to the disease? Does it have any bearing on outcome, these symptoms, so-called prominent symptoms?
I would like to answer that stress is a very important factor when we talk about narcolepsy and all sleep disorders. And when the patient is experiencing too many cataplexy episodes, so his mind is himself not strong. That is what will impact it more for the outcome.
Correct. True. So I think basically what it means is that the symptoms are prominent. If the symptoms are prominent, they have more of social and maybe psychological impact on the patient. Actual impact on the clinical outcome and response to therapy may or may not be there. We are not very sure about that at this point of time, but they have to be treated because this is something which will be with the patient for a otherwise cause problem. So we move on now, and Dr. Paramesh, I'll stick with you again to tell us about the pharmacological treatment of narcolepsy. You have already dealt with it in your lecture, but if you could just highlight the salient features once more, especially given the fact that there are many medications, but what is that which is available with us? What is
Uh,
there which can be practically given safely by a routine practicing physician?
Practically, that we can give right now is the modafinil, because that is the available drug for clinical use in our practice, and also antidepressants like fluoxetine and all. If there is predominant depression and all, but most of the cases will be dealing with modafinil only. The other drugs that I have already mentioned, the SNRI and all, are not available in India. And even though it is available, the first choice remains modafinil only in narcolepsy. And if it is not getting better, then you switch over to the other molecules, is what I read in the literature.
So this modafinil, so what should be the stage? Again, I'm asking a very practical question. So you have diagnosed the patient. Now, every patient will he require pharmacotherapy?
If there is, as Dr. Tanvi mentioned, you give proper nap time in the daytime. Non-pharmacological treatment is very important. You give it psychosocial support, psychological support. You give behavioral therapy, and in milder
Yeah, so
cases,
basically what I'm asking is, suppose you have done all that.
yeah.
So is it that should first we try non-pharmacotherapy approach first only for some time, and if it doesn't work, then we start the pharmacotherapy, or do we start both
But
together?
in type 1, especially if there is cataplexy, we start with the both, because otherwise
So you want to
it may
start with
not be
both
a
in
fruitful
type
thing.
1.
Yeah,
Yeah. So
if
because
it is
that
type
leads
2
to
or
the
a
next
milder,
question.
yeah, it's a milder type. In the type 2 is usually milder without any cataplexy, and if the patient can stay awake, and if there are any other sedating drugs which is going on, alcohol is going on, you remove that, and then still if he's having this excessive daytime sleepiness, then definitely add on.
Correct. Because this leads on to the next question, which was from the audience, and I think you have partly answered that. It was that what is the difference between the treatment for narcolepsy type 1 and 2 also? Is there anything different in the treatment, or is it just that you are more vigilant and you start the pharmacotherapy earlier, maybe in type 1 where there is cataplexy? Or is it the
Obviously, in
same
the
exactly?
milder forms, definitely means we give some time, because these drugs are not without side effects. Though milder side effects, people will have some amount of headaches. People will have some amount of nighttime awakening. All these things will again cause fragmentation of sleep at night, and again cause a vicious problem if not properly titrated. You give it after afternoon hours, then it's going to be a big trouble. So if at all if you're using these drugs, you use it in the morning hours, and you have to up titrate the second dose, mostly to be done after lunch or by before 4 5 p.m. So that is a way by which we treat it. So
And how long do we have to give it?
in severe forms, it most likely will be a long duration, if not a lifelong.
Several years, maybe?
Yeah. It is going to, because these patients may require that. And they can the titration can be done. You can upscale or downscale. But in type 1, basically the orexin is not there. Technically, theoretically speaking, it is destroyed. It is an autoimmune problem, and so definitely, most likely, these patients will
It will be a
require a
long-term
lifelong.
service.
Yeah.
Okay. So I think that also partly answers the question by an audience, one of our doctors, that what are your views on the current options? So modafinil, R-modafinil, and newer agents like the pitolisant and all, you have talked about it. So just quickly, what we have only modafinil practically speaking, but are the other ones, even theoretically, are they definitely better? Is it evidence proved that they are better?
The guidelines says the other two drugs can be used for clinical practice, and there is a strong recommendation for using it in narcolepsy. I
Yeah.
got.
Yeah, but evidence-wise, is it one of them supposed to be better than the other? Because strong recommendation is there for all of them,
Yeah. Strong
almost.
recommendation is for all of them, but the first
Yeah,
line remains modafinil only.
right, correct. Okay, so we'll move on now from the pharmacotherapy. We'll come to Dr. Sushant. Dr. Sushant, my question to you is now, what are these circadian rhythm sleep disorders and what are their types?
No, basically these are the disorders. Now, till now we have seen what is hypersomnia and insomnia, for example, means the sleep-related disorder. This is the disorder where there is a defect in the you can say alignment of internal clock of body with the external clock. External clock means dark light cycle or this you can say sun and moon like that. So if suppose this alignment is not there, what would happen? A person may have a normal sleep. He will definitely have the normal sleep, but he may sleep at the late night. For example, normally socially we sleep at, for example, 10 o'clock. So he may sleep after 2 hours or 12 o'clock or 1 o'clock or 2 or beyond that. And if he's allowed to sleep for longer duration, means in morning, if he's allowed to sleep for the till he wakes up, so he may sleep for almost 8 hours or 9 hours of the sleep. So this is what we call the delayed phase circadian rhythm. Here the phase is delayed, and in this is usually seen in the adolescents and young adults. Nowadays we are very much engaged with social media and that WhatsApp, Facebook. And there is another type of this misalignment. There is advanced phase sleep disorder, circadian disorder. Advanced phase means the person is sleeping at, for example, 7 o'clock in evening, 7 or before that also 7 or 8 like that, and it's awakes at early morning hours. That is somewhere around 3 o'clock or 4 o'clock. So these group of the individuals, when they comes to our sleep clinics, for example, a person who is having delayed phase rhythm disorder, he will come that he's not able to sleep till 2 o'clock, 3 o'clock, 4 o'clock. So we may diagnose it as having insomnia. Fine, because and these individuals may complain of daytime sleepiness also. If suppose socially they are allowed to wake up in early morning, a person sleeping at 2 o'clock and he has to wake up at 7 o'clock. So there is a sleep depth, what you call it. So daily there is a 3 to 4 hours of the sleep depth, and this sleep depth goes on accumulating, and he develops the daytime sleepiness. Then we may misdiagnose it as this group of individuals having hypersomnia or excessive
Correct.
daytime sleepiness.
Correct.
Fine. So these are the two basic main disorders. Apart from this, there are other circadian rhythm disorders, like I told you, that shift worker disorder. Means there is a shift wise duties. So there is no alignment of the internal clock and this dark and light cycle. So these are the individuals who always suffer from many this medical disorders. Like if you have a survey of this group of the individuals, you will find these people are suffering from the hypertension, diabetes, immunological disorders, so many disorders. And again, if suppose there is no alignment of this your internal clock and external clock as 24-hour cycle, specifically seen in the this blind individuals, those who are blind. So that this disorder we call as a non-24 hours sleep wake cycle, sleep wake disorder. And last one is very common nowadays. That is what is jet lag disorder.
Yes.
So when
It's
person
coming to that.
flies, due to rapid travel across the time zone, so the person may develop sleepiness or some cognitive dysfunction sometimes, and some GI upset also. So these are the various circadian sleep rhythm disorders which are
Yeah,
common.
correct. Correct. So I think the last part which you said was also very important because now with all the travel and all, jet lag is so common. It is also a kind of a circadian variation itself, isn't it?
Exactly.
It's a variation in the circadian sleep rhythm. So it's a type of a circadian sleep disorder which
Yes.
many times, which is kind of a self-limiting, as you can call it, in a couple of days. So we move on, Dr. Archana. I'll sticking with circadian sleep disorders. Can you tell us how do we treat these disorders? Generally speaking, what can we do?
It will be usually combination of light therapy, melatonin, and behavioral adjustments. The behavior adjustments is common for all the circadian rhythm disorders like regular meal schedule, regular bedtime schedule, avoiding daytime naps, limiting caffeine and alcohol close to bedtime, and so on. Coming to the individual treatment, in case of delayed deep sleep phase disorder, we need to induce phase advance. So we need to administer melatonin before the desired bedtime and timed bright light therapy in the morning, usually when the patient wakes up in the morning. And in case of resistant cases, so one can give chronotherapy. And in case of advanced circadian rhythm, advanced sleep phase disorder, we need to induce phase delay. So we have to give bright light therapy in the evening and timed melatonin therapy in the early morning hours. So how to remember easily is light pushes the sleep period and melatonin pulls the sleep period. And in case of jet lag, again, the ASM guideline says timed melatonin administration to reduce the symptoms of jet lag and appropriately timed exposure to light depending on the direction of the travel. If one is traveling to the east, again, we need to advance the sleep rhythm, circadian rhythm. And if one is traveling to the west, delay of the sleep rhythm is required.
Okay, so I think these are some things which can be done to try and change the circadian rhythm back to normal. So this just can you explain this light therapy thing that you're talking about? How can we do it? Can anybody do it? How is it done? What light for how long? Is there something?
Usually we use a dose of we use a dose of 2,500 to 10,000 lux, usually given for 2 hours. And it can be given in the form of light boxes or light glasses, like that.
Okay.
Usually, I think we have instruments for that which can be used.
Correct. So I think this requires again a little bit of kind of specialized care for at least for some time for the patient, because one has to set the clock back to the normal, and this usually happens when it is, and obviously not in a jet lag, for something which is more prolonged in those kind of scenarios. So we'll move on, and I'll come to Dr. Mahesh now. Dr. Mahesh, the question I have for you is, the other disorder we talked about was hypersomnia. So can you tell us what is idiopathic hypersomnia, and how does a patient present when he has this disorder?
So we have discussed about the narcolepsy diagnostic criteria and idiopathic hypersomnia. So certain things the patient will typically present with the idiopathic hypersomnia, like the patient will have very long sleep duration. Unlike narcolepsy, they will have a normal sleep duration. They will have sleep duration usually 10 hours, and there may be some of the patients, their sleep duration can go up to 10 to 14, 12 to 14 hours. Again, they have a sleep efficiency more than 90%. But despite having such a long sleep duration, they will not have refreshing sleep. In narcolepsy patient, they will have refreshing sleep. Apart from them, the naps are usually long. They have more than 1 hours of the nap. And as Sir had mentioned that they have a N2 stability. When the sleep spindles appear, they will be stable for a certain period of time. And these patients usually also have some of the other typical sleep features like sleep inertia, or sleep drunkenness, some irritable, their patient will be very irritable after they are wake up. They will have confusion, or they will have some automatic behavior, something like that. And these patients usually have very difficulty in waking up. So with the normal usual alarms, the patient will not wake up. They have to use certain special devices. And as we know that patient will not have a cataplexy, they will have normal orexins, they will have MSL. On MSLT, sleep latency will be less than 8 minutes. They will not be SOREM, or there will be hardly one SOREM. This is a typical thing with which the patient will present.
Okay, so just if you could, I think you have told us a couple of very important differentiating features and symptoms of this entity. So if from the, say, clinician's perspective, I'm sitting with a patient, what are the 4 or 5 history points that we should ask him? to try and find out, like you mentioned a couple of history points. Do you feel fresh out? So what are those 5 or 6 history points that we should ask?
History of point. Am I audible now? Hello? Yes. So, as we know that it is a diagnosis of exclusion. So first we have to rule out all associated disorders, any drug use or any substance abuse. Then patient will have a very long sleep duration and they will have non-refreshing sleep. They will have some associated sleep thing like the patient will have sleep inertia, sleep drunkenness, or they will have irritable or confusion after the sleep. And on polysomnography, there will not be MSLT will show less sleep latency is less than 8 minutes, no SOREMs, and they will have very sleep efficiency on polysomnography, but patient will not have a very refreshing sleep. So these are the some important points which typically clinically can help you differentiate between a narcolepsy and idiopathic hypersomnia.
And one very interesting point you said earlier was that they don't get up with the normal alarm. That's pretty interesting, and I think that's even I'm not able to get up with the normal alarm, and I'm sure many people are not able to get up with the normal alarm. So that is these are some, I think, just on the lighter vein, but these are some things which we can ask the patient, or he may even come out with this history on his own that I'm not able to get up even in spite of putting the alarm. I'm not able to get up and all those. So everybody else gets up, but I'm not able to get up with my alarm. So that is a very common occurrence. All right. So I think with these history points, I think if people can take back home and they can ask, yeah, you want to add something?
So these patients are usually arousable, but the moment they are aroused, immediately they have propensity to go back to sleep. So with a normal usual alarm, they will not wake up. They will have to use a special some alarming system to wake up. This is a very typical history which differentiates from a normal usual variations.
Yeah. Right. Okay. Thank you. So I think we'll move on now, and we'll come to Dr. Tanvi. So we are still sticking with idiopathic hypersomnia. I think already a little bit has been talked about, but is there anything you want to add on the diagnosis of idiopathic hypersomnia per se? How do we diagnose it actually?
So, just summarizing everything, when a patient walks in OPD with symptoms of excessive sleepiness, if the symptom has more of sleep problems, the spectrum is on the severe side of problems, of daytime sleepiness, like sleep inertia, all the symptoms that Dr. Mahesh has explained, we diagnosed as idiopathic hypersomnolence. If there is anything positive like cataplexy or hallucination, it goes towards narcolepsy. If there are night symptoms also present, we do suspect of obstructive sleep apnea. So when we are seeing all these three things, then this is how we clinically differentiate. Then first thing is what we do is polysomnography. So what do we see in polysomnography is increased total sleep time and short sleep latency. So sometimes we may not see SOREMs on MSLT, but we may see that the sleep latency during polysomnography was less than 15 minutes. So that also gives us an insight that it can be idiopathic hypersomnia, because it's a clinical diagnosis. You may always not have everything positive. Second is when the polysomnography is being done properly, and after that you proceed towards the next test, which is MSLT. Usually it is less than 8 minutes, the sleep latency time, and not as severe as less than 5 minutes, which we see in narcolepsy. So REMS, that is initial falling in REM sleep, will be one, not more than one. And if there are no SOREMs, again we can rely just on polysomnography. But other things have to be excluded, that any other medical or psychiatric condition or any drugs which can explain this MSLT, this polysomnography, and all such symptoms have to be explained, along with exclusion of chronic fatigue, chronic sleep deprivation, sleep apnea, and cataplexy.
Right. Thank you. I think
also,
that's
there's one more thing, sorry, I would like to add that if nothing is positive, there's an option of 24-hour polysomnography, which obviously we cannot do with the patient in a lab, but there is wrist actigraphy that we can do. That patient can wear a wrist actigraphy, and we can see that the total period of sleep is more than 660 minutes, that is 12 to 14 hours during the day. If that is positive, that can also help us to diagnose idiopathic hypersomnia.
Correct. Okay. So I think that summarizes the whole thing in a nutshell. I'll stick with you and ask a question which was asked in the chat box. Is there any specific telltale feature in polysomnography to document sleep paralysis? What's your thought on that?
Sleep paralysis, but it will be
Polysomnography.
basically about sleep spindles. So the pattern of sleep spindles will tell us about sleep paralysis and how is the sleep latency. But sleep
Yeah.
paralysis will be basically defined by how often the
It's
patient.
basically more a clinical thing
Yeah,
than a
I don't
PSC
think it will
because
come
there's
on a
not much
not
polysomnography.
in a
correlation. Yes.
polysomnography.
Yeah, so basically, I don't think this will be documented on a polysomnography as far as I understand. Of course, polysomnography has the EMGs and all those things and the belts for muscle for the movements, but that doesn't really document sleep paralysis per se. So I think that remains a clinical diagnosis. All right, so we'll move on now, and I think Dr. Paramesh, idiopathic hypersomnia treatment.
Basic treatment will be behavioral treatment. Give short nap time, sleep hygiene for all the sleep disorders. You give proper sleep hygiene. Good time to sleep means a fixed time for sleeping and fixed wake up time, and also to avoid some stimulants at night. And daytime naps should be scheduled. Sedating drugs, agents, alcohol should be avoided. And the drugs we have already mentioned, it's almost like narcolepsy only. Modafinil is the drug basically, or other drugs which are
We have
not
only this
available for.
modafinil definitely with us
Yeah,
as of now,
yeah,
practically speaking.
yeah,
Yeah,
and
fine.
stimulants like methylphenidate can also be tried
Correct. Right.
for
I think
those
we've
patients.
already talked about this part. So we move on to the next segment. I think we come to Dr. Sushant. And Dr. Sushant, can you tell us, this was also touched upon, what is the clean Levine syndrome? What is recurrent hypersomnia? Can you just shed some light on these entities very
See,
briefly?
recurrent hypersomnia means that the person is having hypersomnia, which is lasting for a few days to weeks, and after that there is a period of normal life, normal sleep, normal behavior. Again, it may be for months or few months like that. Then again, patient will have recurrent another episode of the hypersomnia. So this was the recurrent hypersomnia. And most important disease which can be classified under this recurrent hypersomnia is a Klein-Levin syndrome. You know, here the person will have this hypersomnia, and during that hypersomnic episode, the individual also have some cognitive and behavioral disturbances. And it has been observed that these individuals, specifically they are in the age group of adolescents, and these individuals, they may have hyperphagia or hypersexuality during the episode. And what are the diagnostic criteria which has already been dealt by Dr. Parvez? So they're the recurrent episode of the hypersomnia, which may last for 2 days or more than that. And during the episode, the person should have at least one of the following criteria. What I'm going to tell you. That is what the during episode, there may be a cognitive dysfunction, as has been discussed, that person may be having confusion, derealization, or there could be a behavioral disturbance, hyperphagia. Any of this one condition, if suppose there, then we should diagnose him as a having Cleveland syndrome. And most of these individuals, I have experience of two patients like this, and most of these individuals, they get remission within the period of somewhere around 8 to 9, 10 years, like that. So after that period, they may not have this sort of the presentation, or there is a complete remission. So we need to have the assurance, and then again management remains same, that your modafinil and sleep hygiene is very important aspect of this for to manage the
Correct.
Cleveland syndrome. Yeah.
Correct. Right. Okay. Thank you. So after that, I'll come back to Dr. Mahesh for a question which was asked by one of our audiences. That again, it's a very common question. Among the Epworth sleepiness scale and the stop bang, which is better? Are they the same? Are they meant for the same purpose, or they are meant for different purposes? Which one should we do?
Sir, Ipswich sleepiness score and stop bank score, these are two different scores. The Ipswich sleepiness score, as name itself says, that it is for the evaluation of daytime sleepiness. It is done with the 8 questions, each question 3 marks. The total score is 24. More than 10 should raise the suspicion of excessive daytime sleepiness, and the severity increases once it is more than 16. How the stop bank is usually devised to see the propensity of obstructive sleep apnea related symptoms. The score is more than 5 is more suggestive of likely of OSA symptoms. And this stop bank is majorly used by the anesthetist people, devised by them only. Initially it was a stop, then it was converted to a stop bank score. So for the if it is for excessive daytime sleepiness, it is a Ipswich sleepiness score.
Yeah, so I think they are not exactly the same thing, and they are not also to be used for the same purpose. And like you mentioned that the Epworth sleepiness scale is mostly for this that symptom assessment of the severity of that symptom of sleepiness. Stop bank is probably more holistic. More holistic means it incorporates a more physiological multi-system kind of a parameter, the BMI, neck, BP, everything,
Potential.
age, etc. So that probably is a more holistic this thing and a useful measure for OSA per se. And I think most of us and many of us would be using this as a screening tool per se for obstructive sleep apnea and to decide who are the patients who need to go for a polysomnography. I think that is probably the practical utility of this score. Right. So, okay. So we'll go on to Dr. Archana. I'd like to come to you now with this question of another a new entity, which probably maybe not new, maybe not very confirmed, standardized. Is there some entity known as clinophilia? What is clinophilia and what does it mean?
Clinophilia is a medical condition where the patient will have urge to lie in the bed for a longer period of time without sleeping. That's excessive love for lying in the bed. I think most of us are clinophilics.
Exactly, I was about to say that.
Yes.
So we are
Um,
all clinophiliacs to some extent, at least.
Yes. But they are not standalone disorders by themselves. Usually, they are the symptoms of another underlying condition, like usually like depression, anxiety, or schizophrenia. And they significantly interfere with daily routine activities, workplace performance, and social interactions. So it's important to identify clinophilia and treat it.
All right. So this is also something that basically these were just some terminologies which are there. They may not have that kind of a relevance. They are not so common. We don't know how important are they as of now, but they're basically a symptom-driven nomenclature which has been kind of given. Does it lead to any disease as such? Are you aware? I'm not aware that it leads to any particular disease.
No,
Maybe it's
it's
just a
just a
behavioral
symptom.
pattern.
Yes, it's just a symptom. We need to
Yeah,
address the underlying condition
correct.
associated.
Okay, so I'll move on. I'll come back to Dr. Mahesh again, and we go on to the other spectrum of hypersomnia, which is insomnia. So, can you tell us what is actually the definition of insomnia? What are its various clinical types?
Sir, insomnia is this is an persistent difficulty with sleep quantity and sleep quality. Patient has difficulty in initiating, maintaining the sleep, and this is despite the adequate environment and the adequate time, and this causes the daytime impairment. So it's a quantity, sleep quality, and causes the daytime impairment due to it. So there are various types explained like acute and chronic. If it is less than 3 months, it is acute, and this is related to stress, jet lag, anxiety, or illnesses. And chronic is usually more than 3 months. So the DSM-4 also explains in a different way, like a primary, secondary. Primary has an underlying cause, and secondary does not have an underlying cause. In a primary, it is a idiopathic insomnia, paradoxical insomnia, especially in childhood where it is a behavioral insomnia. And in secondary, it is related to the medical conditions like mental disorders, drug use, or insomnia with objectively short sleep duration. So these are the roughly, but practically, which we differentiate into acute less than 3 months and chronic more than 3 months.
Correct. So one is the differentiation based upon the longevity. That is one, that is whether it is acute or subacute or chronic, and the other would be based upon the etiology. Again, etiology, again, like we said for hypersomnia, there may be a idiopathic type of variety, there may be a secondary type of variety. Similarly, for insomnia also, there is a idiopathic type of variety for which no obvious cause is discernible. And then there may be then there are obviously hundreds of causes of insomnia also, which have to be treated. So that is the other type of variety. Dr. Tanvi, I'll move on to you just as a continuation from this insomnia. Now, we have diagnosed insomnia based on the symptoms, based on whatever Dr. Mahesh has told us. Now, how do we treat it?
Can't hear the question, sir. Pardon.
How do we treat insomnia once we have diagnosed? How do we treat it?
So again, the answer would be first is about sleep hygiene has to be maintained. Usually, insomnia patients tend to take some medications, be it some cough syrup or be it some tablets, and that is not going to help. So first, that needs to be explained to the patient. Second is maintenance of sleep hygiene, that going early to bed and avoiding daytime naps after 4 p.m. That has to be done, and also avoiding any stimulants in the later period and exercise.
Correct. So basically, again, it depends upon one, if we are able to find a etiological cause. If yes, then that is the first thing to be taken care of, whatever be the reason, whether it is any drug or poor sleep hygiene. I think poor sleep hygiene. What do you think? I think I'll leave it to all the panelists. What do you think is the commonest cause of insomnia generally, epidemiologically? Yeah.
It's the phone, the new trend, the new thing is the
Now,
phone. The new
nowadays,
culprit
the
is the
social
phone.
media.
Yeah, social.
Screen.
So I think we all agree on that, isn't it? And to that it is there, and plus I think a strong component of, I think, stress, general stress,
Just
and
increased.
work stress or whatever stress at home, whatever, I think is also a very important cause of insomnia. So these are the two probably most important cause, and we are not going too much into the social aspect of things, but in children, I think definitely social media is the most important cause of insomnia, if I may just generally kind of generalize. So that is one. All right. So coming back to you, Dr. Paramesh, we'll move on and we'll come to we'll stick with insomnia. Is there any term like fictitious insomnia? What is fictitious insomnia, and what does it really mean, and what can be the symptom of a patient in this? How do we diagnose this?
Basically, it is fictitious means it's as the name depicts. The patient is subjectively feels that he is insomniac, but when you test it in a sleep study or something like that, you will definitely have a good amount of sleep detected in the PSG. It's also called paradoxical insomnia. So most likely maybe an underlying anxiety or some other factors may also be there, and may need to have some behavioral therapy and all to deal with that. Drugs
Yes.
not required.
Yeah, drugs not
Drugs
removed.
are
So
not
again,
required.
again, the question will come if somebody, the most common question comes that a person is saying, I'm unable to sleep at night. Should I take anxiolytics? Should I take sedatives? This is the commonest question. Can I take it for one day? Can I take it for a couple of days and then stop it? These are the questions which will naturally come. So I would like to ask the panelists, this is open to all, that again, a very practical question, which it just occurred to me right now, that can we give short course of sedatives or anxiolytics for insomniacs?
What can I take this?
Yeah, Dr. Shashank.
The paradoxical insomnia, what has been described by Dr. Parmesh, what I feel as the PSG is almost normal. This individual has to be treated with a cognitive behavioral therapies rather than this benzodiazepines or some other modalities of this hypnotics, because these patients are not. This is a perception disorder. It's not a disorder of the sleep. Basically, it's a
It is
disorder.
not actually there.
Yeah, it's a perception disorder. He's just sleeping. Yes,
Happiness.
you just demonstrate the individual that on PSG you are having normal sleep, but still you feel that you are not sleeping. So that is a perception disorder. And if suppose you are going to prescribe these individuals this benzodiazepines or any other hypnotics, so they may get addicted to it. They are in fact not needed. So it's better to avoid in these individuals and treat with the cognitive behavioral therapies. Most of the patient, this type of patient respond to the CBT also.
Yeah, so
That's
I
what
think
my concept.
psychological psychotherapy is
Yeah.
probably the way to go in this rather than drug therapy. What about drug therapy in insomnia? Not paradoxical insomnia, but actual insomnia. What would be the treatment of a person who's actually insomniac? What again? Behavioral therapy does play a part. Removal of the cause plays a part. But suppose there is no obvious cause. Suppose there is no stress. Suppose there is no social media, but a person is unable to sleep at night, then what to do? Anybody, Dr. Archana, would you like to take that, or anybody can chip in?
Sir, in such cases, sir, maintenance of proper sleep hygiene is the one of the factor when the no cause is found. So we must stress on maintaining a proper sleep hygiene apart from the behavioral therapy.
Sure. So sleep hygiene again. This is part of
You are
psychotherapy.
actually
Behavioral
asking
therapy.
about the pharmacotherapy, means whether
Yeah, I'm
we
asking
need
what
to
is the
give it or
current
not.
status of pharmacotherapy
Uh,
for insomnia. Although that
uh,
is not, again, I'll say that is
Everything
not the
is
purview of
excluded,
today's
and
discussion.
with along with the CBT, then I think if it is purely detected as insomnia, then we may need
Correct.
to give benzodiazepine based
Okay.
drugs.
So again,
I
this
don't
is
know
not
about
the
the course of the duration of treatment, but I think once everything
short
is
course.
excluded, needs to be initiated if it is proper. If it is fictitious, no drugs, but for proper insomnia, yes.
So okay, so we'll move on now, and Dr.
Melatonin can
Archana,
also be
I'll
added if it is related to circadian rhythm sleep disorder.
sorry, didn't get that.
Melatonin.
Melatonin. Okay, got it. So, Dr. Archana, I'll come to you now and ask you that what is this entity known as insufficient sleep syndrome? When is it called so, and how do we treat it?
This is a voluntary sleep curtailment by the individual himself, leading to excessive daytime sleepiness and impaired functioning. This is considered one of the, it is listed under central disorders of hypersomnolence, and it is associated with serious health consequences like obesity, hypertension, insulin resistance, and cognitive impairment. So again, the treatment is improving the sleep hygiene, increasing the sleep duration, lifestyle modifications, and behavioral interventions.
Right, fine. So, another question came for you, Dr. Archana. I think this was by one of our attendees. Do you think that there is a under recognition of comorbid psychiatric conditions like depression in hypersomnic patients? And if so, how should we address this? So effect of comorbidities, I think we have already talked about. Would you like to quickly elaborate?
Yes, depression is one of the comorbidities which can cause hypersomnolence, one of the cause for the hypersomnolence. So it's important to diagnose the underlying conditions for hypersomnolence, because the treatment of both is entirely different. You have to give antidepressants for depression, and for hypersomnolence, the treatment is different. So we need to address both differently.
So I think the bottom line here is that when we take a history, the history may not only be related to sleep related symptoms, but we will have to go a little bit, broaden our scope of history taking to at least exclude the common comorbidities which can also cause that. So for that, one will need to know, we will need to screen for depression, anxiety. There may be a screening test, maybe the questionnaires are available, or we may send to a psychologist also to kind of clarify that at least there is no psychological condition which is causing his sleep disturbance. So all these things will have to be taken care of before we start our confirm diagnosis and start the therapy. All right, right. Thank you. So next I'll come to Dr. Mahesh, and say we were talking about hypersomnia again. I think this question has been answered before. In a hypersomnic, what are the history wise, again we are coming to history, what should be the history taking of a patient who comes that I am feeling very sleepy, I'm like hypersomnia? What is the history taking? Can you just quickly elaborate on that?
Sir, in history taking, we should ask for the any secondary causes of the hypersomnia, like patient is on some pharmacotherapy, or patient is having some other cardiometabolic disorders, As well as we should take in detail about the sleep history, like duration, maintenance, any concomitant patient, whether patient is having an obstructive sleep apnea, and special attention should be asked for the narcolepsy when there are the histories suggestive of cataplexy and sleep paralysis. Plus, as we know that the sleep duration is when we differentiate between the idiopathic hypersomnia and narcolepsy, sleep duration is longer in idiopathic hypersomnia, and sleep paralysis and other associated things are more in idiopathic hypersomnia. So these are the some of the things which we should ask while dealing with the patient of hypersomnia.
Right. So I think that has already been told. I'll come to from my side the last question, and then we'll quickly see whatever audience questions can be done, and we'll quickly see among the panelists. And this goes to Dr. Tanvi. Dr. Tanvi, can a person have both OSA and narcolepsy? Can they coexist, and how can that be confirmed?
So they are both because of excessive daytime hypersomnolence, but both are distinct and they have different mechanisms how the diseases occur. Usually, what happens is narcolepsy, the diagnosis is delayed because of diagnosing OSA and treating just OSA. So, in most of the cases, the diagnosis of narcolepsy is delayed. So when a patient comes to me, what we can do on OPD basis on what history. So when a patient of excessive daytime or excessive sleepiness comes to you, you have to divide the symptoms into daytime symptoms, nighttime symptoms, and special features. Special features will include cataplexy, hallucination, sleep paralysis, disturbed nighttime sleepiness, sleep inertia. So these are the things that will give you a hint that narcolepsy can be present when initially you are making your clinical diagnosis. Second, when we do the polysomnography, what we can see in that whether the first REM episode or the latency to go in REM is less than 15 minutes or not. Third is when we do MSLT. So in the OSA, if we are doing MSLT, then if there are two or more SOREMs in MSLT, that will help us diagnose narcolepsy. But usually it is not done for OSA. But if we are suspecting narcolepsy, we may do that thing. Both are associated with increased BMI and daytime sleepiness. So they may also be there in a patient.
Right. Okay. So I think now we'll just quickly take some audience questions, and I'll kind of just ask everybody to just in a couple of seconds only answer. Dr. Mahesh, I think I've already pasted here. How do you manage patient expectations? This is more of a social question. Chronic hypersomnic patient, when complete cure is not available, can we manage patient expectations? How can we do that?
Sir, for such a chronic disorder, non-curable disorder, it is very, very difficult to give a patient cure. So the only thing which will give us a proper patient management is counseling. Patient should be counseled about the underlying disorder, and patient may require a long-term modafinil, side effects related to modafinil, as well as it may cause hypertension, or it will cause a difficult to manage hypertension related to it. If it is a narcolepsy related hypersomnia, then patient will require an pharmacotherapy as well as the social or workplace support for cataplexy related events. Plus, they should be instructed to maintain a sleep hygiene and treat the underlying associated disorders like OSA or any other sleep disorder, as well as and these patients will have a high tendency of psychiatric disorders like depression or anxiety related to a long-term illness. So it should be addressed. Plus, this patient should be specially addressed to avoid the driving or handling the equipments which can put a public life in danger, like driving or like public transport or handling
Correct.
big machine.
So I think all these are the long-term counseling which has to be done. I think we have talked about that. But so it is basically, something that has to be told to the patient again and again that look, these are the things to avoid, and pharmacotherapy or whatever counseling that has to continue, as you have already mentioned, and at some point of time one may have some kind of a benefit. Then there are other questions which you have already kind of talked about, importance of behavioral and lifestyle modification and hypersomnia. I think we have already talked about that. Dr. Paramesh, there is a question: what are the challenges in diagnosing hypersomnia in resource limited settings?
Resource limited setting, basically this most of the work is done by the proper history alone. And
Yeah.
if you are,
So I think the only resource limitation will be time, huh? So we
yeah,
have to
time,
give adequate time to take a good history over here. So
definitely.
that resource we'll have to give to the patient.
But once this is one thing that you is less likely to miss the hypersomnolence, because somebody will catch that guy and bring it to you again and again,
Yeah,
or to
sure.
other individual. Mostly goes to the neurologist as well. May not be coming to us.
Okay,
That is
right.
one thing.
So, Dr. Tanvi, interesting question. I think maybe from an undergraduate student, he has posted this question that an undergraduate student has complained of falling asleep in lectures as well as he studies books when within half an hour to 1 hour of study he sleeps. Otherwise, sleep is normal. Can we call this hypersomnia?
No, we cannot label it as hypersomnolence. All of us must have gone through that phase, but that has not been labeled as hypersomnolence. There are other features that have to be present.
Yeah. So because basically this I think I don't think anybody would not have done this or has not gone through this. So I think this is not. So I think they can be rest assured that just falling
Practice
asleep
the sleep hygiene.
occasionally in lectures is not
Ask
hypersomnia.
him to practice the sleep hygiene.
So
That is
that can be the treatment, sir, for the
yeah, yeah,
insomnia.
yeah, yeah, yeah.
Yes, absolutely. So another important, interesting question, Dr. Archana, for you from Vadodara. The question is: any role of Yog Nidra in these kind of excessive sleep disorder, excessive daytime sleepiness, hypersomnias?
I have not gone through the literature.
Anybody else? Anybody? Yeah, because this is not something which is
Yeah, yeah,
as you
yeah. It's
I think
very
yoga relaxes mind, so it may improve the
helps in
quality
sleep.
of sleep.
Hmm?
Yes.
you
But
know
helps in the quality of sleep. Already the person is
actually
sleeping more.
there is a lot of literature available in our the somnology, you can say, that Yog Nidra definitely reduces the or improves the sleep quality, and the people, those who are practicing this Yog Nidra, that means specifically the sort of meditation or shavasana like that, the studies have found that their brain is having on EEG the alpha and theta waves predominant. That means the relaxing
So there
state.
is a role. So at
Yeah, there
least
is
the
definitely
general
a role.
thing is
Yeah,
that there is a role.
definitely there is a role about
Okay,
this.
so I think that is the basic thing. Dr. Paramesh, this quick question from Gujarat: does melatonin really work? So the question is, does it
No,
really work?
but it works for those. I mean, for the specific diseases like the jet lag and all those
Yeah.
circadian rhythm diseases. You cannot give it for insomnia and it won't work.
Correct. So I think we have to know, that when to give what. Melatonin is something, again, it is basically to alter the circadian rhythm to some extent, and that is why it is used for the treatment or rather setting the jet lag rhythm straight. Again, it is not like it is a treatment for any of these hypersomnic or daytime sleepiness disorders. So one has to be very clear on that part. Right. Okay. Another question, I think,
Time administration of melatonin is very important.
sorry.
Timed administration of melatonin is very important to see the results.
Correct. Timed administration is very important. Yeah. Another question: are there special devices to give bright light for circadian rhythm disorders with defined lux and all? So I think, Dr. Archana, you touched upon this. So,
Yes. Yeah, we have light glasses, light visors, and light boxes, which can deliver the bright light therapies. Usually, we give for 2 hours in a dose of 2,500 to 10,000 lux.
okay. So I think
And
that you have already answered, and a couple of questions related to that were there, which has also been
even
answered.
just exposure to the sunlight in morning hours
Yes,
will
bright.
solve the problem. Yeah, morning
Yes,
hours. Yeah.
that may help.
Yeah.
Again, another question: how does your approach differ when managing hypersomnia in the elderly versus young adults? Is there any difference in the management? Again, I leave this open. Maybe Dr. Mahesh can start, or Dr. Archana, Dr. Sushant, anybody. Does age play a role in the management?
I don't think there is any difference in the
I shall.
but for the diagnosis, for diagnosis purpose, for example, like primary this hypersomnolence disorder like narcolepsy or Cleveland syndrome, these are more common in the young adults. Once you diagnose the cause, then management wise, I don't feel there is any difference in the young age and this world.
Sir, as per the age, as Sir has clearly mentioned that this primary disorders will be more in the younger population compared to an older population. If older population is having hypersomnia-related disorders, then we must rule out the underlying medical disorder or underlying
Yes.
psychiatric or any rare neurological disorder. So here sometimes in an older population, we may require a multidisciplinary
Exactly.
discussion with
Like
psychiatrist or
Parkinson's,
neurologist.
Alzheimer, dementia, that was more common in this old age.
Correct.
So
And
diagnosis is
mostly, I
Tend
important.
think
to have
most,
more of
And even the
OSA.
diagnosis is also very difficult in elderly because you may not get the SORMs in elderly. The number of SORMs that you may get may be minimal. And also
yeah.
DD, differential diagnosis, like even brain tumors, the SOLs can also be reasons, no, for
Yeah.
hypersomnolence. I do have a patient right now with CA lung with secondaries in hypersomnolence.
Yeah, so there are
So
again
these are
secondary
things
causes,
that,
yeah, the
yeah,
organic causes. Yeah, organic causes.
organic
Dr.
causes.
Tanvi, quick, you were saying something?
So in older people, we need to look for central apnea, sleep apneas, because that may not be the very presenting symptom, but it may be
Sure, they have
disturbing
to be
their
ruled
other
out.
comorbidities like
Yeah,
hypertension, chronic heart failure,
they have to
or
be ruled out. Yeah,
CNS
correct.
symptoms. Yes.
So again, another question, a general kind of question: can a pulmonologist make a diagnosis of narcolepsy, or neurophysician needs to be involved? So, do we need a
In
Multidisciplinary,
neurophysician?
our setup, we basically have a combined approach.
multidisciplinary
Means,
approach.
yeah, means it's a combined approach basically. Our sleep lab, we discuss a lot, and then only means we do it. It's
Okay.
purely our in my system setup, just like that.
Okay, so last one or two questions. I think we'll then wrap up. Serum, any relation of serum magnesium correlation with sleep? Anybody would want to touch upon this?
No idea.
Not aware of.
I am not aware about any level, any relationship of serum magnesium to sleep pattern or sleep intensity, but we can look at that. What time should melatonin be given? I think that's an important question, but again, we have to be sure for what we are giving it for. It is we should be sure for what we are not giving this for any hypersomnia. Today's topic is hypersomnia and excessive daytime sleepiness. Melatonin is not the cure for that. That is the first thing that has to be understood. So melatonin has got some specific indications, the commonest being treatment of jet lag as of today. So for that, I think
Perceptually.
if one wants to say anything, you can quickly give a line,
For
Dr. Shah.
timing of the melatonin should match with your physiological levels.
Rhythm,
Yeah.
yeah, physiological
Yeah.
rhythm.
Yeah.
Correct. I think
So
that's the
that is
bottom
what
line.
usually, yeah, that's usually, the person who is sleeping at 9 o'clock or 10 o'clock, the melatonin levels start rising around 7 o'clock, in evening.
Okay.
So
So,
just before sleep time, at least 2 to 3 hours before sleep time, I have seen the patient, those who are taking the melatonin at 7 o'clock, and they may sleep at 8 o'clock also. So it's an individual variation also how the person will respond to melatonin. But usually the time duration between the planned sleep and dosing should be somewhere around 2 to 3 hours.
right. So I think one question is again, how do we differentiate hypersomnia from a chronic fatigue syndrome or a burnout? Okay, that again maybe again a practical question, because many patients who come, fatigability, lack of energy, lethargy, so many symptoms are overlapping. So Dr. Paramesh, Dr. Tanvi, would you like to touch upon that? Can we differentiate just like that, or do we need to do the test for hypersomnia and confirm that?
Means the urge to sleep and excessive daytime sleepiness, if it is there, then it is different. But for the fatigue syndrome, it's throughout. It's not that you have this pulsatile kind of episodes. It may not be episodic. It may be throughout the day or throughout the, like there may be underlying depression as well. And
Correct.
I haven't seen anything but in the literature, but I think nowadays vitamin D deficiency is too much for our IT population. That means we
Yeah,
people.
if you go for this, no, the
Yeah.
individuals are having chronic fatigue syndrome or what you call a fibromyalgia
Yes.
like condition, and if
Yeah.
you perform the this PSG of this individual, you will find that there's a difference in the PSG. That
Mm.
PSG will show alpha delta syndrome. What do you call it? Now, alpha waves follow delta waves. Alpha will follow delta waves. So this is a common pattern in the PSG. Those who are having symptoms like chronic fatigue syndrome or fibromyalgia, and most of these patients they do suffer from associated medical disorder that have to rule out, not primarily the sleep disorder.
Okay, I think I'll just take the last question and then we'll close because it's already beyond 10:30 now. The last question, but is there any role for genetic or biomarking testing in diagnosing narcolepsy or idiopathic hypersomnia? We start with Dr. Paramesh, and after that, anybody can chip in if they want to add.
Theoretically, yes. It Some of the diseases goes in families, and certain means even the clean living can happen in these groups where there is more, uh, means means these twins and all can have this issues. So there are genetic tests which are done, but I don't know whether in routine practice we do it. Although the thing is that it is a rarer diseases. These are all rare diseases. In Indian
Correct.
setup, I don't think we are doing it, but yeah,
Correct.
there
I
are
don't.
genes
These are
associated with
probably
that.
mostly research tools.
Research
I think
only.
they will be mostly research tools and not for practical clinical use per se. I just saw one or two questions. Lastly, we'll take them. How do you approach hypersomnia in somebody who's already taking like a depressant, for example, antihistaminics or benzodiazepines? Should we try to? So can we do that? I mean, before doing a PSG and all, we'll have to stop all these, no?
Have to stop
Yes.
and then evaluate the patient.
Yeah,
That's
I
the
think so. The
first
thing would be,
prerequisite to diagnose hypersomnia. That patient is not
yeah.
taking
All
already
of the
anything.
things.
Yeah, so I think the answer here is that if we want to approach hypersomnia, we'll have to do the appropriate test. Before that, we'll have to stop all these CNS depressants. So that is the first thing, and then only do the testing. Do we routinely screen for metabolic syndrome or hypothyroidism in hypersomnic patients? I think it's not a
Yes.
bad idea
Yes,
because
yeah, yeah, it has to
because
be.
secondary causes can be there.
Yes.
All
It has
these things have to be ruled out.
Even for obstructive sleep apnea
Yeah,
patients,
it's very common.
Thyroid
we
is a
just need
must.
to use.
Yeah,
Very
yeah,
common to have
yeah.
hypothyroidism.
So I think now, shall we close? I think we are approaching
Our
10:40.
circadian rhythm is actually
Our
getting
Yeah,
circadian
breached.
rhythm is going to change. So, but I think it has been a wonderful session, and I really must thank all the faculty, all the speakers, panelists today for staying up here and also answering a barrage of questions across the board on this topic. So, thank you very much, and thank you again to the organizing team, to the ICS, and also maximum thanks to the attendees. I think we have had attendees in thousands and questions also in hundreds, and that is why we are extremely thankful to all of you. We hope that whatever was told today, even though it may have been repeated, but the idea to repeat was that at least whatever you learn, you don't forget. So you learn properly. So with this, I thank you once again, and I wish you good night and hand it back to the organizers. Thank you all.
Thank you. Thank you very
Thank
much.
you so much.
Thank you.
Thank you very much.
Thank you, sir. Thank you all. Thank you, fellow panelists.